Good morning, good afternoon, good evening, dear colleagues, dear friends. It is my great pleasure to welcome you all today. My name is Irina Pinchuk. I am psychiatrist. I am director of Institute of Psychiatry of Taras Shevchenko National University of Kiev. I am head of ISAP Ukraine National Chapter. ISAP Ukraine is pleased to invite you to attend the second webinar in a new three-part webinar series on the mental health of youth and substance use. ISAP Ukraine, in this series of 3 webinars, would like to raise issues around youth mental health and bring acknowledgement that is connected with substance use. We invited 3 world-known speakers to talk about depression, self-harm, suicide behavioral, and comorbidity of mental health and substance use disorders in the youth. We had 948 registered for this webinar. This is a great honor for us as well as a huge responsibility. The second webinar will specifically focus on mood disorders in children and adolescents. I would like to inform the attendees of the webinar that you can send us your questions in the chat during the presentation. Please find the chat in the Go to the Webinar control panel. So, it's my honor to introduce Bennett Leventhal, Professor of Child and Adolescent Psychiatry and Medical Director of the Center of Autism Spectrum and Neurodevelopmental Disorders at the University of California, San Francisco, as well as the Irving Harris Professor of Child and Adolescent Psychiatry, Emeritus at the University of Chicago, and Adjunct Professor of Psychiatry at Yonsei University in South Korea. He is a distinguished life fellow of both the American Psychiatric Association and the American Academy of Child and Adolescent Psychiatry, and an honorary member of the World Psychiatric Association. His honors and awards include the Georgian Tejian Awards, Outstanding Mentor Awards, and Catcher in the Raya Awards from the Academy of Child and Adolescent Psychiatry, where he also serves as treasurer and the member of the Executive Committee and Council. He is past chair of VPA Child and Adolescent Psychiatry and treasurer of the American Academy of Child and Adolescent Psychiatry. Dr. Leventhal is active in national and international efforts to promote research and improved care for children and adolescents with psychiatric disorders. He is an active clinician, educator, and investigator. Professor Leventhal, the floor is yours.
Thank you very much, Professor Pinchuk. I'm sorry we can't be with you in Kiev, one of my most favorite cities, where I've been hosted many times by you and your wonderful colleagues. But it's a privilege to be able to present to you today. I'm going to talk primarily about depression in children and adolescents. I'm going to cover a lot of material, but I hope this will be helpful to you in thinking about these common disorders. These are my disclosures. The only one that might be relevant is Johnson & Johnson, where I'm working on a project that has nothing to do with pharmacological agents at all. It's developing an instrument. So why do people think that childhood depression didn't exist for so many years? Well, for many years, they thought that depression was rare in children. And psychoanalytic theory said that people of young age couldn't be depressed because their egos were immature without the defenses to become melancholic. And for many people, developmentally thought that depression existed, but it was different from something that appeared in adults and sort of had a form of something called mass depression or some kind of depressive equivalence. But it wasn't really until the 1970s, led by Citrick and McNew and others, that people began to describe depression in children and adolescents that had very similar characteristics to that which we see in adults, with some developmental modifications. So there are developmental differences in expression of the symptoms, but the symptoms themselves seem to be similar. One of the other things that confounds the story, and I'll show you a bit of data on this, is that we collect information from parents and children, and their perspectives may be different. And finally, comorbidity is very common in depression in children and adolescents, and as a result, that makes the clinical picture somewhat different than one might expect of pure depression alone. In DSM-5, there are a group of disorders that form the category of depressive disorders, from disruptive mood dysregulation disorder to major depressive disorder, dysthymia, and then a few other disorders, including premenstrual dysphoric disorder and substance-induced disorders. If we look at the diagnostic criteria, which I won't go through with you in detail, but DMDD, or disruptive mood dysregulation disorder, is a mood state that's characterized by temper outbursts that occur almost daily and that are inconsistent with the developmental level. And mood between the temper outbursts is persistently irritable. Now, major depressive disorder is the heart of this syndromes, or this group of syndromes, and it includes a variety of depressive symptoms, including depressed mood, anhedonia, changes in weight and activity level, and sleep disturbances, along with feelings of worthlessness and guilt. So hopeless, helplessness, anhedonia, and mood disruption that causes major impairment. Related, but not exactly the same, is persistent depressive mood disorder, previously called dysthymia. And this is depressed mood for most of the day, more days than not, lasting at least 2 years, with some of the symptoms of major depressive disorder, but not all of them, and not necessarily intensively. One of the things that's worth noting about persistent depressive disorder is Criterion C, where they make a modification for children and adolescents. This is the first time in the diagnostic system for major disorders where accommodations were made for development. So children and adolescents only need 1 year of having persistent symptoms. And this is a change that that is reflected with other changes in the terms for dysthymia, which merges two previous disorders, chronic major depressive disorder and dysthymic disorder, into the new category. I'm going to skip through some of this. And then I don't want to bypass premenstrual dysphoric disorder, since it's very important and often unrecognized. Unrecognized because women are often not included in many clinical trials and studies, and the notion that women could have a dysphoric reaction to menses has not been widely accepted, particularly by men who have been doing studies in this area. However, it's now well established, and this is depressive symptoms that come right before the menstrual period begins and ameliorate early in the menstrual, after menses begins. This is a very real and very important phenomenon. Substance abuse depressive disorder is important to remember. It's comorbid, maybe comorbid with major depressive disorder, along with symptoms that are caused by the substances or other medications themselves. Now, when it comes time to making a diagnosis of depression, it's important to not only collect a history and do a clinical examination, but using standard or semi-structured interviews, or using rating scales such as the Kitty SADS and the Children's Depression Rating Scale, or the PHQ-9, CDI, or Children's Depression Scale, the Mood and Feeling Scale, or the CESD for children and for adolescents. These rating scales are important and give us structure to the clinical evaluation of children. Now, there is a natural history of depressive disorders, and that's characterized by remissions and exacerbations or relapses. In general, an episode in children lasts around 7 to 9 months, It could be longer, it could be less, with most cases remitting within 1.5 to 2 years. About 8 to 25%, depending on the study, are chronic disorders that begin in childhood. 56 to 60% of the children with a major depressive disorder will have at least one recurrence, and many will have more than 4, suggested sometimes in the range of 10% or possibly as high as 25% could have multiple recurrences. Most of the recurrences recur within 2 years, the range of 2 years to 5 years. And 60% of the cases that have recurrences may persist into adulthood. The conversion to bipolar disorder, which has been of great concern and some confusion, and I won't discuss in great detail here, has broad variation depending on which report you read, ranging from 4% to as high as 50%. I think it's likely to be somewhere in the range of 10 to 20%, but that's a number that's not entirely clear. In any case, children who have major depressive disorders end up having significant adverse outcomes, including suicidal behavior, drug and alcohol problems, social impairment, and academic impairment, along with the disorders into adulthood. There are no consistent predictors, including age of onset and family history, which tell us who will have recurrence or recovery and who will not. You must follow these patients. If one looks at this epidemiologically, one finds a bit of a challenge. First of all, if you look at parent reports, you find that the rate of report is considerably different between the adults and the children themselves. For teens, for example, in the past year, parents will report 3.5%, whereas the teens themselves report between 8 and 12%. When one looks at the rates of major depressive disorder, one finds that the rate or the prevalence of the illness rises dramatically over time, from childhood in the range of 2 to 4%, by early adolescence, somewhere in the neighborhood of 5%, and by the time one reaches late adolescence, about 15 to 17% of the population may have a point prevalence of about between 15 and 20%, with a lifetime prevalence of something in the range of 20 to 22%. So it's a very common disorder. Now, it's also a very disabling disorder. This is the data from the WHO looking at the disability adjusted life years lost. And unipolar depressive disorders are amongst, if not the biggest cause of disability adjusted life years lost. That's time lost from pursuing regular activities of daily life. So this is a really serious impact, has a really serious impact on children and adolescents. Well, what about comorbidity? I mentioned it earlier. 40 to 70% of people with depression have, children and adolescents have a comorbid disorder. And it almost always precedes the onset of depression. I'll show you that in a moment. 20 to 50% have 2 or more comorbid disorders, with anxiety disorder, disruptive behavior disorders, dysthymia, and substance abuse being the most common. Medical comorbidities, including chronic medical conditions like irritable bowel syndrome, migraine, asthma, etc., may play a really serious role in this. Comorbidity is one of the predictors of severity and length of depression, as well as suicidality and substance use. These are data from some time back, but looking at which came first, depression or mood disorder. In 3/4 of the cases, which came first, comorbid condition or the mood disorder. In 3/4 of cases, the comorbid condition came first, with only 25% of the cases or 30% of the cases having the mood symptoms being present at the very beginning. So when we see patients who have disruptive behavior disorders, we have to, or other anxiety disorders or otherwise, we really need to think about whether there's an underlying major depressive disorder. There are a variety of risk factors, and some of those risk factors actually point us directly to interventions ranging from work with the families to work with the patient. A history of major depressive disorder, parental substance abuse, family history of bipolar disorder, being female or entering puberty, having a prior episode, and having some subsyndromal depression are all biological risks for major depressive disorder. Psychological risk factors include comorbidity, a negative affect or cognitive style, trauma and abuse, poor parenting, parent-child conflict, and bullying all increase risk for disorder. But there are also protective factors that we should keep in mind, and if they don't exist for a child, trying to help development can at least ameliorate the course of disorder. These include positive parent-child relationships, better supervision and monitoring, more time spent with the child by the parents, pro-social or well-adapted peer group, connections to school, and having a higher IQ. For some reason, participating in sports and increased physical activity also appears to be a protective factor. Now, I mentioned before that mood disorders can be dangerous and lead to suicidal behavior. And when we look again at WHO data, we see that suicide is one of the leading causes of death in children and adolescents. These are data looking at the top is both males and females, and orange is females, and yellow is males. The road injury, you'll notice, is the most common in adolescents, but for males in particular, and many of those, some people suspect, may also be related to suicidal behavior, but they get classified as road injuries. These next few slides are courtesy of my colleague Alan Apter from Tel Aviv. The suicide spectrum includes a broad variety of behaviors, including threats, gestures, self-harm, and then, of course, serious suicide attempts. When one looks at suicidality over the course of time, and this is looking over the course of nearly 20 years, one finds that the rate of completed suicide stays fairly stable over time and across age groups. So the top group is adolescents and young adults, older adult, and seniors, but that there's considerable variability in attempted suicide, with suicide attempts being more common in adolescents and less common as people age. As people age, they're much more likely to be successful in their suicide attempts, largely because they have access to lethal means. It's been suggested that there's some personality constellations that are associated with suicide risk, including narcissism and perfectionism, impulsive and aggressive behavior, and hopelessness, often related to the underlying depression itself. Non-suicidal self-harm or self-injury, NSSI, has been suggested to be a non-suicidal behavior. That is, cutting and other things of that sort aren't equivalents to suicidality. But as it turns out, some individuals use NSSI, but then later make serious suicide attempts. So we need to treat non-suicidal self-harm as having a risk for increasing the likelihood of suicidal behaviors. Psychopathology of suicide is also important to remember that most suicide attempters and completers have at least one major psychiatric disorder. By far, the most common of the disorders is mood disorder, and that includes depression and bipolar disorder, with substance abuse, borderline personality disorder, conduct disorder, and other comorbidities being related. So suicidality rarely occurs in isolation and is often the product of an underlying psychiatric disorder. Well, if we know all these things about these disorders, what do we know about treatment? Well, first of all, we need to think about treatment in three different ways. First of all, we need to think about acute treatment. That is, someone presents, they're acutely depressed and need an intervention to start to ameliorate their symptoms. Then continuation, which is the treatment that carries on to prevent relapse, which means it must go 6 to 9 months if the usual untreated episode is 7 to 9 months or 12 months. Most treatments should continue for at least 12 months. And since recurrences can happen up to 2 years after the onset of an episode, Many suggest that one has to think about maintenance treatment for at least a year after the end of the continuation phase of treatment. So at least for a single episode, one needs to think about treatment as a 1 to 2 year process. And for people who have highly recurrent disorder, it may be a chronic condition, that is chronic treatment. What are the treatment tools that we have available to us? Psychoeducation, psychotherapy, pharmacotherapy, other forms of biological therapies, and then there have been a variety of other things that have been suggested. I'll talk a little bit about some of each of these. So what about psychoeducation? This is one that often gets neglected, and I really think it's important that we pause for a minute and think about this. This is beginning to teach your patients about what is depression, what is the illness that they're facing. Now, we don't do this in psychiatry terribly well, but think about what people who are treating diabetes or asthma do, or sickle cell disease, or almost any other chronic disease. They teach them about their disorder, about the causes of it when we know them. We don't in this case. What the signs and symptoms are so they can recognize it early, what the course is so they can appreciate why they need to have treatment, and what the effects of their illness are on their life, and then what treatment is expected of them and how to stay safe. There are studies that have shown that if psychoeducation takes place, that at least it improves adherence and understanding of the illness. It also reduces stigma, and it may help the family member and the patient identify symptoms early and bring them to treatment. Interestingly enough, psychoeducation in and of itself often leads to a reduction of symptoms, which is really important. There are many psychosocial interventions that are also useful for the treatment of depression. While I will spend a considerable amount of time in a moment talking about medications, partly because I'm a psychiatrist and partly because they're so complex, there are a number of psychosocial treatments that have been suggested to be useful for treating depression. This story is somewhat complex. I'll present a little bit of data and offer my thoughts about this, but certainly cognitive behavioral therapy, CBT, and interpersonal therapy, IBT, and to some extent DBT have reasonably good data about treating mood symptoms, as does mindfulness. Interesting enough, supportive psychotherapy and some of the new computerized treatments may have utility as well. Acute treatment of depression with psychotherapy is not an unreasonable strategy. Most studies that have looked at this have used CBT and to a lesser extent IPT, that is cognitive behavioral therapy or interpersonal psychotherapy. These have been studied alone and in conjunction with pharmacotherapy, and I'll show you some data on both. Most of the studies have been done in adolescents, a few in children, and the effects in adolescents seem to be pretty good, and with responses in the 60 to 70% range, but very powerful placebo responses in the control groups, not dissimilar to what we see with medications. So the psychotherapies for children and for adolescent depression include cognitive behavioral therapy, which you're familiar with. Interpersonal therapy for adolescents links onset and perpetuation of depressive symptoms to problems in interpersonal relationships, and helps the individual work through those. IPT really tries to improve the teens' communication and social problem-solving skills, so that they can adapt to the difficulties that they're facing with their mood symptoms and increase their ability to find satisfaction and success in their current relationships and activities. Laura Mufson is the principal developer of this, but there are a number of other people, John Weiss and others, who've been working in this area. This is a study from England where Ian Goodyear and his colleagues took a look at 15 National Health Service child and adolescent clinics in England, and they used 3 manualized psychotherapeutic interventions in nearly 500 adolescents with major depressive disorder. About 390, a remarkable 84%, completed the trial. Comorbidity was common, with anxiety disorder and phobia being associated, and the manualized treatments were all checked for fidelity. One was a brief psychotherapy, 12 sessions in 20 weeks. The other was CBT, 20 sessions in 30 weeks, and then a psychoanalytic psychotherapy of 28 sessions in 30 weeks. The principal outcome measures were the mood and feelings questionnaire, the revised Children's Manifest Anxiety Scale, and the Case-Ed's depressive subscale. And this is the way the outcomes looked, that over time. Brief psychotherapy, it was the first blue bar, orange is CBT, and then the darker or far right-hand bar is psychoanalytic psychotherapy. As you can see, no particular treatment was more effective than the other. They were equally effective. Now, why that was is not entirely clear. It is important to note that 20% were taking Ssri'S prior to therapy, and 40% used Ssri'S at some point during the course of therapy. But that didn't seem to affect outcome. I suppose the important lesson here is when administered in a structured, manualized way, many forms of treatment, psychotherapeutic treatment can be helpful in the treatment of acute depressive episodes. I'd also point out that these follow-up was out to 86 weeks, which is a long period of time in a study and suggests enduring successful effects of psychotherapy in the treatment of depression. So what psychotherapies worked? There are many randomized controlled trials, and there have been a number of meta-analyses, and it seems quite clear that IPT and CBT are better than controls at both immediately post-treatment and longer-term follow-ups. They're more effective than play therapy, and they appear to be more effective than just problem-solving therapy and psychodynamic psychotherapy in the most trials outside of impact. What other psychotherapeutic treatments are also available? Some people suggest family therapy, school-based therapy, and internet-based psychotherapies. There are more data about the internet-based psychotherapies in the past few years, and they're mixed again, but suggesting that at least some children can be successfully treated over the internet remotely using internet-delivered psychotherapy. What are the large controlled major depressive treatment studies? Well, there are two large studies with long-term follow-ups. One is the TADS, the Treatment of Adolescent Depression study, which had 3 arms, a CBT plus fluoxetine arm, fluoxetine, and a placebo arm that was done 12 weeks. And medication was used, and then there was an open treatment phase followed by 36-week follow-up. Whoop. The other one was the ADAPT study, the Adolescent Treatment Antidepressant and Psychotherapy Trial. Brief CBT didn't help much in addition to the fluoxetine, with 60% responding in 28 weeks and 80% in a year. Now, this is a British study, and they were somewhat sicker than the TADS sample, but nonetheless, I think the outcomes were both favorable. This is a quick look at the TADS data at 12 weeks, and you can see CBT plus fluoxetine looks like it did better than fluoxetine alone, both of which were much better than CBT, and CBT was only slightly better than placebo. Statistically, the CBT plus fluoxetine and fluoxetine were not statistically significantly different from each other, and it was originally thought that it meant CBT was not terribly useful. However, at 36-week follow-up, it appeared that there was no difference between the CBT plus fluoxetine, and CBT alone, suggesting that in the short term, CBT plus fluoxetine or SSRI might be a better way to go. In the longer term, it might be that they would be equal. And as I'll show you in survival curves, it may be that CBT is better in the continuation phase, or at least essential part of that. Now, there have been a large number of clinical trials, now at this point, dozens and dozens, if not hundreds, looking at various antidepressants for treating major depressive disorder in adolescents. Some have proven to be better. Citalopram, not so better than placebo. escitalopram, or the brand name in the United States is Lexapro, somewhat better. And most studies with fluoxetine have shown that fluoxetine is definitely better than placebo, both in children and adolescents. Then this is looking at paroxetine, sertraline. Sertraline was better in one study, not better in another. And so you can see the story is oftentimes mixed, and with some not separating at all, like duloxetine, venlafaxine, and desvenlafaxine, not differing from placebo. So sertraline, maybe paroxetine, and fluoxetine look like they may have some utility. The point here is that the acute treatment of major depressive disorder using SSRIs is likely to be helpful, with a response rate in the 40 to 70% range, depending on which drug, which placebo, the placebo response, as well as dosing, etc. And remission rates are currently looking like they're in the range of 30 to 40%, which means that major depressive disorder often turns out to be a chronic condition for many patients. This is looking at fluoxetine in a placebo-controlled 8-week study, just like this is Emsley's study, but just like in the TAD study, in the short term, it looks like fluoxetine is quite helpful for perhaps as many as 40 to 50% of adolescents. This is Karen Wagner's study of sertraline. Once again, sertraline looks a little bit better, statistically better than placebo on 2 different measures, but not dramatically better. These high placebo response rates are really quite important to and interfere with analyzing these data. Now, because SSRIs are used for other conditions, and some of which may be comorbid with depression, it's important to look at that as well. And one of the things that you see on this particular slide is that while it's effective, and SSRIs are effective in treating major depressive disorder, they're even more effective in treating obsessive compulsive disorder and in treating anxiety disorder. So if you have a comorbid condition, adding the successful treatment of the comorbid condition may actually improve the overall outcome for depression itself. And then this is looking at combined treatment with CBT and SSRI. These are longer-term studies. This is a Clark study looking at a year out, and the difference between control and CBT alone is not that robust. And looking at the difference between SSRI and SSRI plus CBT is not that robust. So the data are somewhat mixed, although I think in general, the conclusion is that SSRIs increase remission rates, decrease the number of symptoms, prevent recurrences, and lower suicide rates, but most importantly, improve overall psychosocial function. So while the measures, like the various measures that we use in treatment, may not always capture the differences, and while placebo or control may do very well over time, even with modest support, it looks like the treatments that we're thinking about are at least helpful for many patients. Now, what role does dosing play in all this? Well, apparently it plays a significant role, at least in adults. Higher doses, patients on higher doses do better. But if you get too high, it causes side effects and leads to dropouts. So at least for adults, it looks like moderate to high doses of SSRIs seem to make some sense as you raise for patients who at least are not getting better. We'll come back to that in a moment. And this is looking at a meta-analysis of the absolute benefit attributable to antidepressants in response to SSRIs. This TAD study, which is on the far left 2 bars, but then looking at fluoxetine studies, paroxetine, sertraline, citalopram, venlafaxine, mirtazapine, escitalopram, nifazodone, and overall treatment effects, which are pretty uneven along the way, as you can see. But it seems quite compelling to consider fluoxetine as an effective treatment for depression in children and adolescents. So when is the first response to SSRIs evident? Some people say it takes months. Well, it turns out when you look at the studies carefully, it looks like the initial responses to treatment on major depression rating scales is as early as 1 week. So within 1 to 2 weeks, you should be expecting to see a treatment response, that is reduction in symptoms on rating scales. The meta-analysis of 13 trials, 65% of the patients had improvement compared to placebo by week 2. This is a very important thing to remember. And at least with respect to initial response, age, dose, and SSRI type didn't really matter. Now, I think it's important as people who think about treating patients like this need to remember what the half-lives of these drugs are. And that may play a critical role in how you dose. Given the long half-life of fluoxetine, it may really be a distinct advantage, and one of the reasons why it may be superior. And their blood levels are even higher in children than they are in adults. You shouldn't forget that there are side effects, and side effects are common, including gastrointestinal side effects, sleep disturbance, nightmares, sexual side effects, which are not trivial in adolescents, increase and decrease weight, agitation, and switching to bipolar disorder. There are rare side effects such as serotonin syndrome, and I'll come back to suicidal ideations. Activation is not a trivial problem with SSRIs. It occurs in children and adolescents more common than in adults. It's not really well studied in children and adolescents, but it appears to be higher in that population. Why, or why it happens, is it immaturity or comorbidity is not entirely clear. But it might have diagnostic significance. Now, I just want to remind you that there's a black box warning, at least in the United States, but in other countries, saying that there's an increased risk of suicidality related to SSRIs. Remember that suicide risk declines over time with drug treatment. So it appears that it's quite a bit higher in adolescents, children and adolescents, than it is in older adults. So this phenomenon may be developmentally sensitive. Exactly why it's more developmentally sensitive is not clear. The data themselves have been collected largely by spontaneous adverse event reporting. That is that the monitors of drugs ask people to report what their symptoms are. But at this point, it appears somewhere between 1% and 3% of individuals on antidepressants have an onset or worsening of suicidality in response to the treatment itself. It's relatively rare, but nonetheless an important side effect for which one we need to monitor. Withdrawal symptoms are also something we need to pay attention to, largely for shorter half-life medications. It includes flu-like symptoms. It's why we need, in the psychoeducation portion of the treatment, to warn the patients about this possibility so that they will withdraw the drug under guidance. So in double-blind placebo-controlled trials, as I've said before, antidepressants have varying efficacy. And this is just looking at a spectrum of drugs that have been used, SSRIs and SNRIs. And you can see a couple things that are important. Most fluoxetine studies have been successful. Sertraline has been successful. Citalopram and paroxetine uneven. Venlafaxine, not so much, but difference between children and adolescents, the same with the citalopram. No RCTs for bupropion, and nifazodone, mirtazapine, and selegiline have been negative. Tricyclic antidepressants, the data are uneven, but the anticholinergic side effects make them so dangerous, particularly for overdose, that we tend to stay away from these drugs. There's also been a study of omega-3 fatty acids, just to show you I'm not skipping anything that was shown not to be effective. There are also newer medications like vilazodone that have been around recently, and they have not been terribly successful either. Now, why is it that the response rates are so modest or inconsistent? First of all, there are high placebo response rates, particularly higher in children than adolescents, and always higher than adults. And this may vary with the year of the study, so it's not entirely clear. Pharmacokinetics are different in children, so dosing may have to be not taken into account carefully and may not have been. And duration of illness may play a role in this. And some people think that higher rates of bipolar disorder in children may decrease response to the treatment. And certainly the duration of the trials at 8 weeks are not long enough. Clearly trials of 30 to 50 weeks need to be important. And we may be missing the whole role interaction between comorbidity and other phenomena. And finally, drugs just may not be as effective. But what about patients who have treatment-resistant depression? And these are the indicators of poor response: persistent severe depression, people who don't expect the treatment to work, less than 50% of the symptoms get better during the first 4 weeks, poor coping skills, poor adherence, socioeconomic status, family conflict, and parental depression all are indicators of likely poor response. There is an excellent study by David Brent and his colleagues called TORDIA, the Treatment of Resistant Depression Study. What happens if the first SRI doesn't work? From this study, they suggest increasing the dose may work first. Adding CBT may also work. And they saw no response difference between SSRIs and SNRIs. The efficacy of venlafaxine was similar to SSRIs. There were many, many more side effects. When you looked at the TORDIA data, it looked like patients who got CBT in addition to the medication did better and significantly better. So that's important. So possibly non-responders who've been only getting medication adding CBT may make a difference. But whether you're on an SSRI or an SNRI probably didn't make that much difference. And furthermore, if you didn't respond to one SSRI, there is some reason to think about trying a second SSRI before going even on to an SNRI. So this is a very important bit of work that came from David Brent. And what about inadequate responders, those who you've tried everything? First of all, you need to start with the diagnosis, make sure you got the right diagnosis. Then look at whether the treatment was adequate, the dose, the duration, adherence, if there are pharmacodynamic or pharmacokinetic factors, side effects, and whether comorbidity was playing a role in the course of the disorder. This is just to remind you that you have to really pay attention to dose, particularly in treatment-resistant patients. And now I want to just make a few closing comments about continuation treatment. This is survival curves looking at patients who receive drug and placebo. And what you can see is the red line are the medication that this one happens to be paroxetine, and looking over time that those patients who got medication certainly did better for a longer period of time. And that medication plus, in the right-hand plot, medication plus CBT, their survival curves were far better than medication management alone. Now, the medication management alone may have had less adherence when they didn't get CBT as well. So it looks like CBT plus a medication over a long period of time, this is a 30-week study, looks like it is the way to go in avoiding relapses. And this is another study, the same, looking at the same thing, now out to 78 weeks. And so that effect tends to hold, CBT with medication versus CBT alone, a medication alone. All right. Now, before I close, I just want to talk about a few other new treatments. One is RTMS, repeated transcranial magnetic stimulation. This is newly available. The data on adolescents is virtually non-existent, but there are now a few studies to look at which would suggest that in treatment-resistant depression, using RTMS may be very helpful in patients who have otherwise been non-responsive to medications and other treatments. So this is something to keep in mind and to watch the literature going forward. And finally, the matter of ketamine. Once again, the literature is lacking. I would call your attention to European Child and Adolescent Psychiatry published this week, a paper by Kim et al. Attempted to do a systematic review. They found only 4 papers that seemed to be roughly meeting criteria with careful examination. 3 did not. But overall, the impression was that they improved depressive symptoms, decreased suicidality, reduced mood lability, but that not all patients responded. So this is an evolving story, but once again, something to think about for treatment-resistant patients. So in summary, depressive disorders are common in children and adolescents. Comorbidity is the rule, not the exception. And if you're not sure and you're not making progress, maybe a good idea to even get a second opinion when the diagnosis is not clear. The benefit of most antidepressants in children and adolescents, with the exception of fluoxetine, is modest. And so depending solely on antidepressants probably isn't a good plan. You have to be alert for side effects, both uncommon ones and common ones, including suicidality. And for non-medical therapists, child psychiatry involvement should begin early in the process so that medications is done collaboratively with other kinds of treatment and isn't delayed unnecessarily. Involving educators is critical, both in terms of making accommodations, but also early identification. And sadly, we still don't know the etiology. Acute treatment recommendations for mild disorder begin with psychoeducation support and case management, but if symptoms persist over 4 to 6 weeks, then specific types of treatments need to be administered. But if the patient has severe symptoms, persistent depression, increasing melancholic symptoms, psychosis, or other factors, then initiating pharmacotherapy and intensive psychotherapy with CBT or IBT is likely the way to go. And if antidepressants are going to be prescribed, using evidence-based to determine which treatments to use, most likely fluoxetine will be the starting point, but understanding prior responses and comorbidity plays a role. And then you have to carefully monitor for side effects. Depression in children and adolescents, really, we need to remember this, is common. It affects probably somewhere in the neighborhood of 15 to 20% of all children at any one time. It's recurrent. 50% of children, 50 to 60% of children and adolescents who have one episode will have a second episode. And of those who have a second episode, perhaps as many as 15% of them will go on to have a third. And of that group, even a significant number will have a chronic course. It's a painful illness. It's one that causes great discomfort for children, adolescents, and their families. It's debilitating. It interferes with schoolwork. It interferes with social life. It's dangerous because it can increase the risk of self-harm, including suicidality. But most importantly, it's treatable. It's treatable very well with a combination of CBT, IBT, and medications. So with that, I will stop and be happy to answer any questions. Thank you very much.
Thank you very much, Professor Bennett Leventhal, for a very interesting presentation. Now we have time for some questions. We would like to thank our participants for submitting this question. The first question: how do you describe your typical patient with depression? What symptoms should alert patients, school teachers, and healthcare professionals?
Well, so the cardinal symptoms of depression are the ones that are certainly well spelled out in the DSM, but I think the ones to pay most attention to are, first of all, sadness, mood symptoms associated with sadness and melancholia. Secondly, anhedonia, the loss of pleasure in doing things that you previously liked to do. Those are very prominent symptoms that occur early. But I think you should never forget the fact that comorbidity often occurs at the beginning of depression. So changes in behavior, behavioral disruptions, behavioral problems often appear before the mood symptoms themselves. So when we're looking at children, when the parents tell us that your child isn't doing well, that they've changed, they're just not what they used to be, and that they're having symptoms that may at a mild level be developmentally appropriate, but have become more severe than we'd expect at that developmental level, then we need to pay attention and start considering diagnosis and treatment.
Thank you. The next questions, do we need to talk with siblings at school about the depression of their classmate?
Oh, that's a wonderful question. Whoever asks that gets gold stars. We talked about psychoeducation, and psychoeducation certainly begins with the family and the patient. But to the extent that it's possible to talk to teachers and perhaps even to peers about what their friend is going through so they can understand depression and be supportive of them is a wonderful thing to do. It's not always possible. Families don't want to tell. There's some feelings of stigma about it. But if a child's friends can know what they're going through, they'll be far more supportive, and it will definitely help the outcome for the child or adolescent. It's a very good idea and should be thought of as an intrinsic part of the psychoeducational component of treatment.
Thank you. The next question, do parents of the child with depression should also receive psychotherapeutic treatment and maybe medicine?
Okay, that's another very good question. So since there's seems to be a substantial genetic component to major depressive disorders, the first thing any clinician should do when they diagnose a child is make sure that other people in the family don't have depression. That means parents and siblings, perhaps even extended family. If they have depression, then they need to be treated. If they don't have depression, they don't need to be treated for depression. But parent guidance plays a really important role in the treatment of depression. How is it that you help your child as they struggle with depression? And it's important for two reasons. Number one, parents get frustrated because they want their children to be well and to be happy. And if they can't make their children well and happy, it becomes demoralizing and frustrating for them. The second is that the parents need to be responsive to the needs of the children. So a child who's depressed and they say, oh, come on, get up, let's go outside, you can do this. And if the child is really depressed and can't, helping the parents support the child until they can actually resume normal behavior and give them alternatives is a really important part of the treatment. So treating parents may not be necessary unless they have their own diagnosis, but parent guidance and parent support and including them in the treatment process is essential.
Thank you. A lot of questions. I read the question. Maybe this question, relationship between social media and depression in adolescents and children.
I knew that was going to come eventually. There really are no particularly strong data about a relationship between social media and psychopathology. And unfortunately, I think the community, the mental health community, is sort of divided into two parts. One part thinks that social media and video games and all kinds of media like electronic media cause all manner of bad things to happen in children. And then there are a group of people who think that that social media and video games and things like that don't have a particularly significant impact at all. And I think the answer probably falls somewhere in between, but we don't have enough data to really give us a clear answer. I think the important part of the story is that for children who become completely absorbed in social media or in the electronic world and don't have any other outlets, it can clearly be problematic, especially for children with depression, because they can get into social media groups with other kids who share a very dark view of the world, and it promotes their anhedonia, promotes their negative outlook, etc. So I think the real key is not actually whether it's social media itself or video games or anything of that sort, but rather parental monitoring and making sure that there's an appropriate amount of time and that the interactions themselves are appropriate, rather than condemning social media by itself. Indeed, in some settings, social media can be really quite helpful because they can find support groups and find outlets that can be quite positive for them as well. So I don't think it's social media itself, it's how social media is used and monitored that makes the difference.
Okay, thank you. Maybe two questions. Do clinicians use any application that can be downloaded on the adolescent's mobile phone and support subject with depression?
That's a really good question. So there are, and I'm sorry I didn't actually review this, but there are mobile apps that have been suggested to be useful, not only for being supportive, but actually mobile apps for treatment of depression. There's also using remote psychotherapy, equivalent to Zoom or whatever else you're using, to provide both psychotherapy and support for individuals with depression. Unlike ADHD, where there actually are approved indications using video games, there are not yet at this point, although my understanding is that there are applications that are in with data that would be online supports. Everything now will be deliverable, or virtually everything deliverable on smartphones. So I would monitor this and see when data-driven or evidence-based interventions are available, but I think that's imminent. People sitting around during COVID have been thinking about all kinds of things, and this has been one of the areas where there's been considerable progress.
Thank you. Next question, what about kids with epilepsy? Should Ssri be prescribed? Are some better or worse than other in this comorbidity?
Wow, another excellent question. Thank you. So first of all, children who have any chronic illness, including epilepsy, are at increased risk of depression. And when they get depression, their depressions are likely to be more severe and longer lasting. Secondly, many of the anti-epileptic drugs themselves may have antidepressant qualities. And so a child with epilepsy who has depression may get treated with their anti-epilepsy drug. But certainly there's no contraindication for the use of fluoxetine in someone who has epilepsy. Some of the other drugs, particularly Ssri'S, may increase the risk of seizure diathesis. So one needs to check with their epileptologist or their neurologist before you prescribe most other drugs. Ssri'S in general should be okay, though, for children with epilepsy.
And maybe last question. What do you think is the role of resilience in the development of mood disorder symptoms, specifically in treatment and possible outcomes?
Wow, another excellent question. So let me take and I'm going to expand that question just a little bit. So not only what do I think about resilience, but also the role of adverse childhood experiences, or ACEs. So some children are very resilient, but they still get depression. So depression, just because you're very resilient, doesn't protect you from depression, but you're more likely to get engaged in treatment faster, have a better treatment response, and be able to sustain that treatment for a longer period of time with less severity and less relapses. That appears to be the case. But what contributes to resilience? Why are some people more resilient? What is a measure of resilience? That's less clear and more problematic. Certainly children who have had fewer adverse childhood experiences are likely to be more resilient. But the question is, do they have fewer adverse childhood experiences because they're resilient, or because there's something biologically unique about them and that's what helps them become resilient? And the answer to that question is not so clear. But I would advise you to consider the work of a man by the name of Tom Boyce, who talks about differential susceptibility. And he suggests that some individuals developmentally are more or less susceptible to events in their lives. And those who are more susceptible have a bimodal advantage. Either they're more susceptible to adverse experiences, but they're also more susceptible to positive experiences. So if you are more susceptible, but you have lots of good things happen for you, you're more likely to be resilient to such things as depression. On the other hand, if you have bad things happen to you, not so much. Then there are a group of people who are not that susceptible to the environment, and no matter what happens, they seem to plod along and do pretty well in spite of almost everything. He wrote a wonderful book called The Dandelion and the Orchid. I don't remember the entire name, but I really would recommend that. It's a wonderful book and gives an interesting story of his career, but also about the differential susceptibility of individuals. And I think that's as good a way to think about resilience as any.
Thank you very much, Professor Bennett Leventhal, for your very interesting presentation, for your great contribution to this event. I would like to thank everyone for participating in our webinar. I would like to say thank you to our technical support, and looking forward to meeting you soon at the next ISAP Ukraine event in November. Thank you very much.